Dr. Kshitij Malik. I'm an audio vestibular physician by training. I did my specialization from University of London about a decade ago, and have been running my vestibular labs and audio vestibular clinics in Delhi for the last 1 decade now. Now, we're going to talk about nystagmus today, and all great civilizations, when they start, they go through 3 existential phases. The first phase is the phase of survival. The second phase is the phase of inquiry. And the third phase is the phase of sophistication. About 5,000 years ago, the humans were thinking, what do we eat? Do we eat a rock? Do we eat a piece of wood? Do we eat fruit? So that was the phase of survival. Then came the phase of inquiry. Why do we eat? Well, it gives us energy. We are able to move when we eat. The concerns with glucose metabolism, insulin, all that came later. And now all of us are in the stage of sophistication. Where do we eat? I need to have some dosa. Which is the best restaurant that serves dosa here? That's the primary question. Likewise, I'll bring the phase of survival, inquiry, and sophistication into the phase of nystagmus and figure out why do we have nystagmus? So what is nystagmus, number one? What is it to do with? And then the phase of inquiry, why do we have it? And the phase of sophistication. If you see a kind of nystagmus, which is a localizing lesion that's leading to that nystagmus. The presentation will flow from a simple concept and go more and more advanced. I would request your undivided attention for the next 20 minutes, and I promise at the end of this presentation, any localization will not take more than a minute. So you see nystagmus, you will be able to localize it into what canal is being involved, what's happening where at the end of the presentation. Now what is VOR? Everyone knows that. VOR. It's the single most important reflex that we have that helps in gaze stabilization. Basically, we have the vestibular semicircular canals. Each canal is pushing the eye to one direction, and it has a complementing pair from the other direction. So when the eye is at rest, my right horizontal canal is pushing the eye to the other side, to the left side, and the left horizontal canal is pushing the eye to the right side, and both of them are equal, symmetrical, and there's no motion. The moment I move my head to the right, my right semicircular canal becomes more active or stronger than the left horizontal, and it's able to push the eye to the other side. So I'm able to maintain my gaze. Which means that we have the right and the left horizontal canals, which are giving equal and opposite force. We also have the right anterior, left posterior canal pairs, and the left anterior and the right posterior canal pairs. So all these semicircular canal form pairs, which at rest are giving the eye equal and opposite push to one side, which cancels each other out as we go ahead. The eye movement occurs in the 3 planes. In nystagmus, will occur in 3 planes, which are called the yaw, the pitch, and the roll. Now, some of you know what the yaw, the pitch, and the roll planes are. Some who don't, let me give you a small idea how I remember them. The yaw plane sounds like the word no. Yaw is no. And how do we do a no? Is this. So this is the yaw plane. Yaw is like no, which moves the head like this. So this is the horizontal plane, yeah? This plane. The next plane is called the pitch plane. How do you remember the pitch? Well, when I think of the word pitch, it reminds me of a pitcher of beer. And when somebody asks you, do you want to have a pitcher of beer? The only right answer to that question is to nod your head like that. So this is a pitch plane. Remember, anyone says pitch, pitcher of beer? Yes, that is the only right answer. Trust me. Understood so far with me? All right, perfect. So people who have not understood so far would do the yaw plane. People who have understood so far will do the pitch plane. But most of you who are Indians will do something called the Indian head shake, which is the roll plane. Yes, sir. No, sir. It's the same. So Indians are the people who invented the roll plane, I would think. In these 3 planes would nystagmus occur. So you have the nystagmus, which is purely horizontal. You may have nystagmus, which is purely vertical. And you may have nystagmus, which is also torsional. Now, the semicircular canals, based on the muscles they provide, will have the nystagmus in one of these 3 planes or combination. Mostly it's a combination of the 3, which tells us what is involved. Before we go to the canals in particular, let's talk about the extraocular muscles. What you have at the top part of this picture is, here. So what you have here are the muscles, but on this part, what you have is the movement that each muscle does. So basically, when the eye is moving up, it's either the superior rectus or the inferior oblique. Okay? So any motion up is either superior rectus here or the inferior oblique here. If the eye is moving down, it's either the inferior rectus or the superior oblique. And if the eye is going to sides, it's either the lateral rectus or the medial rectus. The function of the superior rectus is taking the eye up and also moving the top part towards the nose. So it's intorsion also. The primary function is up, the secondary function is intorsion. And the primary function of the superior oblique is taking the eye down and also intorsion. Okay? So the easy way to remember is superiors are intorters. The superior rectus and the superior oblique both will intort the eye, that is, take it towards the nose. So in case of my right eye, if you see intorsion, you would think it's going clockwise. On my left eye, if you think intorsion, you will think it's anti-clockwise. Okay? From here on, we'll go to the more important topics in hand. Okay? Done. Now we are at the VOR. We discussed the VOR of the horizontal canals a while ago. So now let's concentrate on the vertical canals. If my head is going down, so if you keep your finger in front of you and you put your head down, you're stimulating the anterior canals. Where did the eye go? It went up. So you do this. So if I'm stimulating the anterior canals, my eye is going up. So the anterior canal function, the VOR, is to take the eye up. Likewise, if I look at my finger and put my head back, to keep focus, my eye will have to come down, which means the posterior canals bring the eye down. Okay? So the anteriors are taking it up, the posteriors are taking it down. What happens if I do an isolated anterior canal? So when I'm doing this, I'm doing both, right and left. But if I turn my head to 45 degrees in a plane, say on the right side, and move my head down like this, my eye is going up, and my right eye is intorting, okay? Because the right eye, the right vestibular canal, is stimulating the superior rectus on the ipsilateral side. So superior rectus and superiors are intorters. So my right eye will intort. If I'm doing it on the left side, my left side will intort. So the upshot of this entire conversation here is that the vestibular ocular reflex of my right anterior semicircular canal is to take the eye up and to intort the right eye, the same eye. You will think it's a clockwise action. So it's a clockwise movement if you're looking at me. So if you're looking at a subject and the eye is going clockwise, that is the vestibular ocular reflex of the superior anterior semicircular canal. If you're looking at the right posterior canal, the eye will go down, but it will still be clockwise. So the vestibular ocular reflex of the right side to the onlooker is clockwise motion. The left side to the onlooker will be anti-clockwise. So if you see a VOR which is clockwise, it is the right. If the VOR which is anti-clockwise, to you, the onlooker, it's the left. We'll at the moment stop at that. So the two concepts that we remember here, one, the VOR of the right anterior canal, the anterior canals is the eye going up, and on the ipsilateral side of the right side, the eye going clockwise, on the left side, anti-clockwise to the onlooker. Normally, we should use the word intorsion and extorsion. I'm using clockwise, anti-clockwise to the onlooker to make it simpler. Okay? With this, with this, we'll go to the problem of a hypofunction of a canal. Now, what is compensation? Compensation is when, for example, in terms of, let's say, I earn 100 rupees a day, and my partner earns 100 rupees a day, and there's a boss. So he says, you keep on working, and if for some reason you don't work, I will compensate you for your loss. So if I can't work, I don't get my 100 rupees, the boss will do it for me. He'll give me 100 rupees instead. That's what compensation is. If the anterior canal stops working or hyperfunctions, the central system will take over the stimulus, the work of that canal. So if my anterior canal, which was otherwise doing the work of taking the eye up and clockwise, hyperfunctions for some matter, the fast phase will be taken up by the brain, and the nystagmus I will get in the hyperfunction of my right anterior canal is the eye going up and clockwise. So if you see a clockwise nystagmus, upwards and clockwise nystagmus, the clockwise will denote it's the right eye, The upward nystagmus will denote is the anterior canal, and that's what you will get. Simple so far? Okay. In the left canal, in the left anterior canal, what nystagmus will I get? For a hypofunction of left anterior. Anterior canal means it will be up, and left means it will be anti-clockwise. Simple enough? So this is the case of hypofunction. Now let me add another layer of complication here. What we are talking is the hyperfunction of the right, which means the right and the left are here. If the right hyperfunctions, this is nystagmus, but you will get the same nystagmus if the left posterior hyperfunctions. So the right anterior canal hyperfunction and the left posterior canal hyperfunction will be the same nystagmus. So this is also the nystagmus of left side BPPV. Okay, left posterior canal. But we'll keep that aside. Chiefly for the sake of discussion, I'm talking about vestibular neuritis patients. We're not talking about BPPVs at the moment. So we're not talking about hyperfunctioning of the canal pair. We're talking about the hypofunction of one canal. We'll come to the hyperfunction in a minute. So what we've understood so far is anterior canal will cause, hyperfunction will cause the eye beating upwards, and a right side problem will have it clockwise, a left side problem will have it anti-clockwise. Simple enough. Now let's go to the posterior canal. Yeah, by the way, that's Malik's first law. I just devised it last night. Nystagmus fast phase of FC hyperfunction is the same as contra hyperfunction. Okay? The reverse explanation will hold true for a right posterior canal. Now, if it's a right posterior canal lesion, a posterior canal nystagmus will be hyperfunction. Nystagmus will be downbeat or upbeat. A hyperfunction will be downbeat. A right side will be clockwise. Okay? So if you see a right side downbeating nystagmus with a torsion, you're probably isolatedly looking at a right posterior canal hyperfunction. Okay? Let's come to the left posterior canal damage. Left side nystagmus, anti-clockwise. Posterior canal downbeating, so if it's an anti-clockwise downbeating, it's a left posterior canal damage. Okay? Quick recap. Anterior canal hyperfunction is upbeating. Please. We're talking about fast phase. Yes, yes. Okay, what I'm telling you is, okay. So, if my right, so let's only discuss the fast phase. I'm just keeping it simple. If you see a jerk, the nystagmus beating towards upwards and clockwise. Upwards is anterior canal, clockwise is right. So upwards clockwise nystagmus is right anterior. Upwards anti-clockwise nystagmus is left anterior. Any anti-clockwise nystagmus you see is the left side. Any clockwise is the right side. Okay, fast phase. Of course, nystagmus beating towards the fast phase. Okay, so it's a little confusing, but let's see. So let's have this video here, and is it playing here? Yeah, good. So is it a clockwise or an anti-clockwise movement? The torsion. It's a clockwise or an anti-clockwise? Anti-clockwise. So it's the right or the left? Left. Is it upbeat or downbeat? Downbeat. So it's the anterior or the posterior canal? Posterior. So this is an isolated left posterior canal damage. Now left posterior canal damage isolatedly can occur in an inferior vestibular neuritis. Okay? So if the patient comes to you within half an hour of 1 hour of illness, you will probably see this. This will sort of, over time, you will not probably see it, but with the Cyclops system, if you see, you'll probably be able to, without fixation, get this picture. Okay? Now let's have a look at this. What is this? Is it upbeating or downbeating? It's upbeating. Is it clockwise or anti-clockwise? It's clockwise. So upbeating, anterior canal, clockwise, right side, so it's right anterior. But it also has a horizontal component to it, which means the horizontal canal is also being involved. So right anterior and right horizontal will make the spectrum of a superior vestibular neuritis. Okay? Okay, now this one is clockwise, anti-clockwise. Anti-clockwise, upbeating, downbeating. Upbeating. Anti-clockwise left, upbeating anterior canal, and also a horizontal component to it, which makes it a left superior vestibular neuritis. Right, and now this one, is it upbeating or downbeating? Well, it's not beating anywhere. So it's horizontal, yes, but does it have a torsional component to it? So the torsional component is clockwise and anti-clockwise. So it's a right-sided problem. We neither have an upbeating or a downbeating. Why is that? Yeah. So the point here is, let's come here. Yeah, so let's come here. Now in this, your right anterior canal is it's sort of cutting off your superior rectus function. Your right posterior canal is doing I'm sorry, let me get that out. Okay. So your right anterior canal is supposed to take the eye. The fast phase will be upwards and clockwise. The right posterior canal, fast phase will be downwards and clockwise. So the up and down are getting cancelled, and what you are left with is only a torsional component. So in case of a total vestibular problem, the anterior, posterior, and the horizontal canals all going out, what you will have is that there'll be neither an upbeat nor a downbeat, but only a torsional component. And based on that torsional, if it's clockwise, you can deduce it's a right side problem. If it's anti-clockwise, you can deduce it's a left side problem. Is that clear so far? So, in summary, normal function, no nystagmus. Dysfunction of one canal, the pair becomes dominant. The slow phase is the dominant canal function, and the brain compensates by giving a fast phase in the same canal VOR, which is affected. So this is what it is in case of a peripheral nystagmus of a hypofunction. We are not discussing BPPV. All those nystagmus we saw were at the spontaneous nystagmus phase. We have about 3 minutes left in the presentation. Peripheral versus central. Everyone knows this. Most of this is simple. We'll very quickly go through it. The nystagmus of a peripheral problem is always unidirectional. It doesn't change directions. It doesn't become right-sided on one position or left on the other. While a central nystagmus can change nystagmus position. It can be right beating on one end, left beating on the other, can become pan-changing, can become up beating, down beating, anything. The second thing is suppression on visual fixation. Peripheral will suppress, central will not suppress. So if you're doing a spontaneous or a bit, you would do it with light, without fixation, and with light, and you can see the changes in the pattern. And the third thing, which mostly is seen, is a pure upbeating or a pure downbeating. Now, vestibular problems which are coming from the semicircular canals will always have a torsional component because they stimulate either the superior rectus, superior oblique, inferior rectus, or inferior oblique. So all of them do not only have a pure taking eye up or down function, but also have a torsion intact. Now, unless you have a right anterior, left anterior both affected, which is very rare, you cannot cancel the torsional component. And therefore, any peripheral bit will also have some torsion associated to it, while a central nystagmus may happen without any torsional component whatsoever. This is a diagram that just says, or just shows you how the nuclei are in the brainstem. So you have the vestibular nuclei, which is also along with the nucleus ambiguus, the 10th nerve, 9th nerve. You also have hypolocusal nucleus with the vestibular nucleus. So anything that happens in the brainstem may not only affect the vestibular function, will also have effect on the other functions. To understand this, let's look at this. Now, assume that the peripheral bit are all the M&Ms of a single color on one side. If a thief was to come and strike, he might only take the blue ones and leave everything else intact. If a thief wants to take only red ones, he might only take the red ones and leave everything intact. However, in the central, everything is so close together that any thief or any attack will not only destroy one specific color. You know, once you're taking a handful, you will have some green, some blues, some reds, everything combined. So a central cannot be focused on only one system. It will always have other systems involved to an extent. It may happen in the later stages. In the early stages, you might not see it as often. But over time, a central a problem will not restrict itself isolated to the vestibular symptom, but also have other things like dysarthria, dysphagia, hemiparesis, and so on and so forth. With 8 seconds to go, Dr. Pradeep, do I have another 2 minutes? I can, thank you. So let's see vascular syndromes in medulla. We'll go very early here. Now the commonest is Wallenberg syndrome or the lateral medullary syndrome. It's because of an infarct of the posterior inferior cerebral artery. Now if that happens, what you see, the area of lesion is here, somewhere here, which means it will involve this area laterally. Now you don't only have vestibular nucleus here, you have so many other nuclei also. And therefore, commonly you will find that the patient will have nystagmus, yes, but also problem with dysarthria, hemisensory loss, facial numbness, and so on. Okay, I'm sorry, I'm not done yet. Couple of more slides to go. The medial medullary syndrome will also involve the part that you see here, this bit. So you also see a collection of nuclei are affected here. Coming to the cerebellum. Now the cerebellum has 3 main organs: the dorsal oculomotor members, the OVM. You have the flocculus and paraflocculus, and the nodulus and ventral uvula. Now the problems chiefly of dorsal oculomotor vermis are saccadic problems. The flocculus and paraflocculus will chiefly have problems with gaze holding, pursuit, and optokinetic nystagmus. And the VOR problems are nodulus and ventricular. All the nystagmus produced by the cerebellum will have the feature of a central nystagmus. That means fixation may not have a large effect, which also means that it might be gaze changing, it might change its position on gaze, and so on and so forth. Now I anticipated that I'll be running out of time, and I also understand that this topic is so thought-inducing and sort of, it takes so much of you while you're trying to understand that I even labeled the hourglass with the sand and hourglass. You don't have to sort of put any more effort in understanding this than you have to. We have congenital nystagmus. Now, congenital nystagmus is, it typically develops within 4 to 5 months of age when the vision fixation has started. It can be infantile pendular, like moves as a pendulum, or it can be latent, in which you have to close one eye and get the other one. It normally gets the entire life on, it doesn't get better, and so on. You can have gaze-evoked nystagmus. We had a case with Brunt's nystagmus some time back. Brunt's was gaze-evoked on one side, large amplitude, on the other side, low amplitude. We have rebound nystagmus, asymmetrical gaze. Now, all those central nystagmus will have features of central nystagmus, which we just discussed. We don't necessarily need to go in detail, at least not in this forum. As long as you can understand which is peripheral, which is central, and if it's peripheral, the movement can tell you whether it's the right beating, left beating, if it's the which canals are involved, that should suffice more or less. That concludes my talk. I'll end with a quote, because all good people end with a quote. Thank you very much.